today we have an exciting and important topic that a lot of progress is being made in this area of learning about our genetic risk of Alzheimer's disease. It's pretty complex, but with advancing technologies, we've learned a lot, especially over the last probably 3 years. And there's constantly things coming out, new information. A lot of the publications and data I'm referencing are like within the last 12 to 18 months even that these were published. So it's constantly changing and has many implications depending on if this is for, say, you have a family member who has Alzheimer's disease or some kind of neurodegenerative disease, or maybe your spouse has this, and you're thinking about your children's risk and what that means and when we should find out. So hopefully I'll dig into a number of these things, and feel free to put any of your questions into the chat. I'm going to share my screen here. All right. For those of you who haven't joined before, Dr. Dani Cabral, I'm an Alzheimer's specialist, neurologist, and psychiatrist, and founder of BrainLove. Today, we're going to talk about what we know about the role of genetics in Alzheimer's disease risk. So that means risk specifically is person doesn't have any symptoms yet. And so what is their chance of developing symptoms in their lifetime? And we'll learn about this most well-established risk or susceptibility gene called ApoE4, and talk about the pros and cons of getting tested for ApoE. And what does that mean for prevention and treatment of Alzheimer's disease? So I refer to this slide a lot if you've been to any of my talks. And it's very relevant to what we're talking about today. So it's been 130 years. Oh, I need to change this year here. It's been 130 years since Dr. Alzheimer identified this woman, Auguste Dieter, and she was 51 when he was working as a psychiatrist in an inpatient unit, and noticed that she was developing significant cognitive changes and memory loss very quickly, along with these neuropsychiatric symptoms and psychosis, which is why she was in the inpatient psychiatric unit. So she was quite young, and he went on to look at her brain after she died. So she died at 55. This is 1906. And what he saw were these what we now call amyloid plaques and tau tangles. So he was also a neuropathologist. So he would do these autopsies, and these were surprising to him, these findings. And so fast forward many years later, I'm not going to go through all this, but this is I think a nice depiction of what's been going on in this field for the past, almost 130 years. Now, that was 1906 when Dr. Alzheimer described this first case of these changes in the brain that went along with these changes clinically in real life. And so then fast forward to the mid-1980s, we developed technology that we could then look at the amyloid and the tau, and that was through brain autopsy. We could see that. And then we also determined that people who develop Alzheimer's disease, some of them have these genetic changes, and you can see in the red circle here, this is amyloid precursor protein gene and other genetic linkages. We saw that the people who had these genetic changes tended to have these amyloid plaques building up in their brains earlier and quicker. And so just as a reminder, probably many of you know at this point, but the Alzheimer's changes start building up in the brain 20 years before any symptoms start. So that's really in midlife. And you can see here the x-axis horizontally, this is over time, and then the y-axis vertically is the change, the magnitude of change in these biologic factors related to Alzheimer's disease, and then the clinical changes. So first we see these amyloid plaques building up starting 20 years before any symptoms, and they ramp up pretty quickly and plateau as we're hitting MCI, which is mild cognitive impairment. So those are the first symptoms of Alzheimer's disease. And then later on, these tau tangles show up closer to the symptoms. In terms of what we know about the genetics contributing to Alzheimer's disease, it turns out that 75% of cases, 3/4 of cases, do not seem to have a familial or genetic component to them, but 1/4 of them do. And so what that 25%, how that's defined in terms of, we call it familial, that's if you have 3 or more individuals in your family who've been diagnosed with Alzheimer's disease. Now, that's a little challenging. That many, I've heard people come through my clinics and research programs that have said, well, I've had a number of family members who've had symptoms, but they were never officially diagnosed. So I would say you can go by if they've had symptoms. And so these would be blood relatives. So say your parents, grandparents, aunts, uncles, depending on your age, could be your siblings. And there, within that familial category, there are these much rarer individuals who develop symptoms of Alzheimer's disease at very young ages, like in their 30s, 40s, and 50s. But really the 30s and 40s, we call this young age of onset. And you can see, if you look at this pie chart, that that's the green. And that's less than 2% of people who have Alzheimer's disease have these very rare young onset presentations. And it turns out they typically have what I'll talk about in a second is these autosomal dominant Alzheimer's disease mutations. So they get this gene from a parent and they have 100% chance of developing Alzheimer's disease symptoms in their lives. And they almost always develop them at a very early age. Then within that, we also have within that young age of onset familial cases, individuals with Down syndrome, almost 100% of them will develop Alzheimer's disease symptoms if they live long enough. And so you can see in the the pie chart, that's the blue, less than 1%. Now, the people who let me talk about these young onset individuals. So it turns out that Auguste Deter, who Dr. Alzheimer identified in 1906, she turns out later was able to determine she was a carrier of one of these autosomal dominant Alzheimer's disease mutations, which is called presenilin 2. So we know there's 3 of these. There's probably more that haven't yet been defined, but there's mutations in the amyloid precursor protein, the presenilin 1 gene, and the presenilin 2 gene. And so again, these are very, very rare. People who have these develop symptoms like in their 30s and 40s. And I've, in my entire clinical career, seen about maybe 6 to 8 patients who I know have this. And they tend, they develop the symptoms very young. They are often, they tend to have like teenage kids because they're in that like the 40s age range. The disease course goes faster and it's pretty devastating, of course. And that has major implications. So if we think about Alzheimer's disease, traditionally, it starts later in life. We don't have an accurate idea to predict exactly who's going to get that later onset of Alzheimer's. So it's harder to study these individuals who are older when they get it because it's so unpredictable and the course is so unpredictable. Whereas we have this group here, this young onset group, that if you have these mutations, it's pretty much 100% certain these people will go on to develop the symptoms of Alzheimer's disease, and they do it at a predictable rate. They're younger, the disease progresses faster. And so they are a perfect group to study, to learn about the disease and to develop treatments, and hopefully with the goal of helping them. And certainly these individuals who have participated in research studies have made huge contributions to our understanding of the disease that in many ways relate to the rest of the majority of the people who are getting, late onset Alzheimer's disease, which is more in the 60s and later. Let's shift. So we talked about these rare young onset cases of people who get symptoms in their 30s and 40s, who have these autosomal dominant genetic mutations where they have, once they have the gene, they have 100% of getting the disease. So that's very rare. Whereas the rest of that, if you think about that pie chart, that 25% familial is really driven by this ApoE4 gene. And so this is a susceptibility gene, and this is going to be the core feature of the rest of this talk, because this is really what's relevant to the majority of people who are concerned about their Alzheimer's risk, who have a family history. Now, the ApoE gene, it's not well known exactly all of its functions. It's involved in lipid metabolism and has other roles that we still don't understand entirely. Now, we get a copy of the ApoE gene from each parent, and there's 3 possible options we could get. There's 3 variants. There's ApoE2, ApoE3, and ApoE4. We get a copy of each of those from each parent. This ApoE gene, if you are interested, is located on this chromosome 19. You can see here. Now, with these 3 variants of ApoE, there's 6 possible combinations that a person could have. There's 2-2, 2-3, 2-4, 3-3, 3-4, and 4-4. You can see here the arrow that shows which portend lower risk or higher risk of developing Alzheimer's disease. So the ApoE4 is the higher, is more, puts a person more at risk of Alzheimer's disease during life, whereas the ApoE2 is a lower risk. And the 3 is an average risk. Now, therefore, since the ApoE4 is the higher risk susceptibility gene, those who have 1 or 2 copies are at an increased risk. And specifically 3 ApoE3, 4, or 4, 4. ApoE2 actually is protective against Alzheimer's disease. So people who carry 1 or 2 copies of ApoE2 tend not to go on to develop Alzheimer's disease. They likely have risk of developing other diseases. Now, as you can imagine, in my job as a memory specialist, I rarely see people who are ApoE2, because the people who are coming in, whether they're symptomatic or they're coming in for prevention studies, they often have a family history. So there is less likely to be an ApoE2 there, although I have met people who just generally were curious about themselves and their cognitive and brain health and ended up having the 2. So now 42%, it's important to note, this is very important, that just because you don't have an ApoE4 gene does not mean that you will not develop Alzheimer's disease. So 42% of individuals with Alzheimer's disease do not have an E4, 1 or 2 copies. And those people are typically 3-3, so they have this average risk of developing Alzheimer's disease during life. Now, in terms of who has, a 3 or a 4 that has Alzheimer's disease, so 15% of people with Alzheimer's disease are ApoE4-4. And in the US, 2% of the entire US population is ApoE4-4. So it's much less common, certainly. 25% of the US population is a 3-4. So they have 1 copy of the 4. And the 3 again is like the average risk of developing Alzheimer's disease. Studies show that in terms of if you're a carrier of 1 or 2 copies of E4, the risk of developing symptomatic Alzheimer's disease by age 75, if you have 1 copy, so if you're a 3-4, it's about 15% increased risk during life by age 75. So really not that much big of a difference compared to that average risk. And if you're a 4-4, there appears to be a 35% chance of developing symptomatic Alzheimer's disease by age 75, and maybe up to a 60% chance by age 85. So it is certainly an important factor and increases susceptibility to Alzheimer's disease symptoms, but it's not a slam dunk. It's not definitive. And this is, of course, crucial as we're talking about the possibility of getting tested for this, and to find out, say you have you're a 4-4, it's not a certainty that you will develop Alzheimer's disease. And I have had patients come through who were 4-4s and did not have Alzheimer's disease changes in their brain. Actually, people who were older and had cognitive changes or concerns, but turns out, these people are in their 70s and 80s, and they don't have the Alzheimer's changes in the brain, so the amyloid plaques building up. So that's very meaningful. Now, there's a lot of information here. I won't read through all this, but what it's appearing is that people who have 2 copies of the 4 may be a distinct form of Alzheimer's disease that needs to be viewed entirely separately from everyone else who has Alzheimer's disease. This is a recent study that was published. I think it's really well done. So they looked at over 13,000 people from these data sets over time. This was through a group at Harvard that's very prolific. And what it showed was that people who were 4-4 had more Alzheimer's disease changes and significantly higher levels of Alzheimer's biomarkers starting at age 55 compared to those who were 3-3. So we're talking about people that have that average risk. They don't have a copy of the 4. So ApoE 4-4 compared to 3-3. So if we look at this graph up top that kind of looks like sunset with the orange and the yellow and the pink, the first part of that are people who are ApoE 4-4, and it's their age in the horizontal, and the percent of chance of Alzheimer's disease changes in their brain by that age. And so you can see in the legend, you see the orange is a high score on that. The Alzheimer's disease changes, the amount of changes. So you can see early on, even in the early to mid 50s, you're seeing intermediate to high burden of Alzheimer's disease neuropathologic change in people who are ApoE 4-4, and that persists regardless of the age at death. And very few people who have, or the purple, who have no Alzheimer's disease neuropathologic change. And again, that's the amyloid plaques and or the tau tangles. And so if we look at the right graph, the ApoE 3-3, we can see that looks much differently, and that depending on the age at death, there's a high burden for less than half of those individuals. And there's certainly a good amount that have no Alzheimer's disease neuropathologic change throughout their lives. And very few people, to go back to the 4-4, who have most people have changes in their brain. Whether or not they have symptoms, that's a whole other story. But once again, we know that where this field is moving, it's to think about the biologic changes completely separately from the clinical changes, and really trying to get at what's happening with the biologic changes and how can we predict who's going to get those. So going back to the text here, by age 65, what this study found is that almost all ApoE 4-4 individuals had abnormal amyloid levels in their cerebrospinal fluid. 3/4 had positive amyloid PET scans, so they have elevated amyloid plaques in their brain, with the prevalence of these markers increasing with age, indicating near full penetrance of Alzheimer's disease biology in ApoE 4-4 individuals. And so that term, full penetrance, harkens to these individuals who have these autosomal dominant Alzheimer's disease early onset, very young onset cases where they're predestined to develop the Alzheimer's disease changes. And so the caveat is that these individuals didn't all develop symptoms of Alzheimer's, but they did have these brain changes much more commonly. And then the next bullet here, the age of symptom onset was earlier for those who are ApoE44. It was at 65.1 years old, with a narrower prediction interval than ApoE33, which was 7 to 10 years later. And then you could predict the symptom time onset and how the biomarkers would change more reliably in the ApoE44s, which mirrors the autosomal dominant. And so the last bullet here I think is really interesting. So what this says is that in the dementia stage, there were no differences in amyloid or tau PET across haplotypes. So that's 33, 34, 44, despite earlier clinical and biomarker changes. So what that means is that once a person gets into that clearly symptomatic stage with dementia, with changes in their thinking and their function, you can't tell the difference between what you're seeing in their biologic changes, regardless of their genetic findings. And so that means that people who are pre-symptomatic, younger, midlife, younger than that even, are much more variable in what their course is and what their biologic changes is and how things are progressing. And so the advances in our technology and our understanding of the disease to now be able to identify all these things earlier on before there's any symptoms is so valuable to help us clarify subsets of people and different variants of this Alzheimer's disease, which, I think we'll end up finding out it's like 30 or 50 different diseases. And there'll be unique treatments for each of those, treatment combinations. Now, I just wanted to mention something that's come out of a pretty exciting finding recently. This was just published. It's an Alzheimer's secondary prevention trial, which means people who have these Alzheimer's biologic changes, but they don't yet have symptoms. So trying to prevent the symptoms from starting based on these autosomal dominant young onset individuals who have these mutations like the amyloid precursor protein mutation, the presenilin 1 or the presenilin 2. So there's this big cohort study coming out of WashU in St. Louis called DIAN-TU, Dominantly Inherited Alzheimer's Network. And so they just published this open label trial that showed that they treated individuals who were pre-symptomatic, who had these autosomal dominant mutations. They've been treating them with these anti-amyloid monoclonal antibody treatments. And those that were treated for 8 years had a 50% less chance of developing symptoms of Alzheimer's disease compared to those that didn't receive that level, that duration of treatment. And that's, you can see in this graph here, this is the treated group. It's called gantenerumab, that's in the blue, and the red is the controls. And probability of progression is going up. So going up is getting worse symptomatically. So you can see the difference over those 8+ years. And that, of course, is hugely meaningful. Now, this is open label. So there's different groups are getting different things and they know what they're getting. And so people aren't blinded to that they're getting this treatment. And so that limits our ability to interpret and feel confident that this is truly effective, but this has never been shown before. And this is so exciting and promising, especially, first of all, you can imagine if you're in these families and you have this, you find out you have a mutation. Previously, there was really no hope for effective treatment. And so this might point towards something that could be helpful. And then also, could this mean if we project to the rest of the people, most of us who don't have these autosomal dominant mutations, could we start treating people who have, say, who are ApoE44 and appear to have a high risk of going on to develop symptoms for different reasons. Besides that, could start on these treatments, you know, in their 40s or something like that. And if they take them for many years, it's going to significantly decrease the risk of developing symptoms. Like, that's really exciting possibility. Now, this, interestingly, this decrease in the risk or halving of the risk of developing symptoms occurred even though these people's participants' amyloid plaques did not completely disappear. They were not fully cleared. And so they're still hanging in there without symptoms despite having these amyloid plaques in their brain. So there's a lot of questions about what that means. And then these patients are now enrolled in a trial using a different medication called lecanemab to clear the plaques, because we know this is a really effective plaque clear, to see if that can continue to slow the progression to symptoms. Now, for those of you who don't know, these medications like lecanemab, this is already approved for treatment of individuals who have early symptomatic stages of Alzheimer's disease, like mild cognitive impairment or mild dementia, because in our trials, it was shown to significantly slow the progression of symptoms of cognitive and functional decline compared to placebo. So this area of anti-amyloid medications is the first big class that is showing promise and has been approved for 2 medications. All right. Now let's shift to talking about Alzheimer's genetic testing in research in the real world. Now, essentially, what we're talking about here is ApoE testing to see if you are a carrier of the ApoE4 gene or not. So currently, that can be tested with blood test or a cheek swab that's sent for DNA analysis. It's not recommended or covered by insurance yet for any reason, except for individuals who are being considered, for individuals who have mild cognitive impairment or mild dementia due to Alzheimer's disease, and it's been diagnosed, and they're being evaluated to see if they can start these recently approved treatments like lecanemab and donanemab. And I'll talk more about why in a minute. Otherwise, though, there's still a question of what will you do with this information? How will this change your life? How will this change management clinically or medically? How will your healthcare professional, what will they do with this information? And will it be a service to your life? And I'll talk more shortly about things to consider before getting tested. And as we talked about, so if you did get tested, the results would be one of these 6 combinations. And there would, however, be no formal counseling provided typically. There's, in my experience clinically, genetic counseling is not covered for this reason, except for people who are these very young onset, these very, very rare cases of these autosomal dominant Alzheimer's disease gene mutations. And many genetic counselors actually aren't well-versed in Alzheimer's disease. They're very well-versed in cancer genetics and counseling on cancer and some other diseases, but not so much Alzheimer's disease. And that's reasonable, since we're just now getting a better understanding of what the genetic implications are beyond these autosomal dominant cases. There is direct-to-consumer ApoE testing available. People can go do these tests on their own. However, that is not recommended. As you can imagine, or if you've thought about this, you're on your own when you do that kind of testing, and they provide very minimal counseling and support through these companies. And so if you get a result that you're not happy with, it can be really scary and really anxiety provoking, and you may not have a clear place to turn to get counseling and support. When I was in my fellowship year after my residency, that was at Butler Hospital in Rhode Island. And we had a brain health registry, and we were grant funded for people to come in to have the ApoE testing done. And as part of that study, there was a lot that went into determining the reasons that the person wanted to know their ApoE, what we call their psychological readiness. How would they deal with these results? Do they grasp the implications for themselves and their families? If they were an ApoE 4/4, how would it change their lives or not? There's certainly concern that people may act rashly or impulsively if given these results without support. And this really has to do with that we don't fully know. We can't fully predict what will happen to a person if they are an E44. So I'm going to talk more about the pros and cons in a minute, including these questionable protections for things like long-term care and life insurance. This is a lot of graphs here, but what I just wanted, the reason I brought this to you is because when I said that people who, there is the variable insurance coverage of ApoE genetic testing for people who are being considered for these new treatments for Alzheimer's disease. So the reason is because if a person, these drugs, these anti-amyloid monoclonal antibodies, which really effectively clear the amyloid plaques in the brain, the concerning risk that these carry, the most concerning, is that they can cause fluid shifts out of the blood vessels as the amyloid plaques are being removed, and that those fluid shifts or blood shifts can cause microhemorrhages or swelling in the brain that, while it's typically very manageable and typically asymptomatic, that is a concerning risk factor that we need to monitor for. And the reason that ApoE testing is recommended is because the biggest risk factor for having those side effects from those drugs, and again, those are only for people who are in the early symptomatic stages of Alzheimer's disease, is that an ApoE 4/4 individual, that's the biggest risk factor for developing those side effects. And so you can see in this first graph, this is noting all of the things that they found increase the risk of the side effects. So it's called ARIA, amyloid related imaging abnormality, or ARIA. And so you can see there's ApoE4 genotype is number one, then there's microhemorrhages, superficial siderosis, mean arterial pressure. So these are different things. I'm not going to talk about these right now, but the point is you can see on the right, the ARIA, increasing ARIA association by far is people who are ApoE4 homozygous, which means ApoE 4/4. And then on the right side is the ARIA H, that's hemorrhages or bleeds, frequency by ApoE4. And so you can see the white bars are the non-carriers, so they don't have a copy of the 4. Heterozygous is a 3/4, homozygous is a 4/4. So you can see the percentage of participants who developed, and this is for donanemab, who developed these microhemorrhages or bleeding, it's notably increased for people who are ApoE 4/4s. Now that doesn't mean, I just want to say that this is not an absolute contraindication to pursuing these medications, but it's important to find out your ApoE status to get counseling on your risk of these side effects. Okay, now let's shift to maybe the question that you're asking and you want to know is, should I find out my ApoE status for myself? So here I've just laid out some pros and cons to keep in mind. So pros, increased awareness and planning. If I think going back to what I said earlier and what the data is showing, it really seems like the most powerful finding here, the main finding that would lead to action, is if you are an ApoE 4/4 individual. There's certainly increasing evidence to show that that is a clear increased risk for developing Alzheimer's disease during life in a more predictable way biologically and symptomatically. And that may propel a person to act in a variety of ways to decrease their future risk of developing symptoms. Whereas a person with one copy, so there are 3, 4, there's a slightly increased risk, but not that may incite some changes, but not to the degree that knowing you're a 4 is. So increased awareness and planning. I've had individuals who go through our, research programs for Alzheimer's prevention who find out they're 4, and this has led them to exercise more, eat better, be more socially engaged, and take all sorts of positive health actions in their lives, and thinking about long-term planning, financial, legal planning, and getting involved in research studies, clinical trials, some of which they could consider being given a treatment. So these are being studied, these anti-amyloid monoclonal antibodies are being studied in people who are cognitively unimpaired, but they have elevated amyloid in their brains. And so they are at a higher risk of going on to develop symptoms. So if you found out you were ApoE 4 and say you're, 55 years old, you may be more inclined to want to get into these one of these clinical trials where you'd have, like a 50% chance of getting the active treatment, and or, you're contributing to science and learning a lot and getting integrated into a community of brain health. Family risk insight could be a pro. You learning your status has implications for your children and their children. Potential eligibility for trials or interventions. There's a number of trials that do seek to enrich their studies with people who are ApoE 4 specifically, or a 4 carrier, and there's some clinical trials of treatments for Alzheimer's that only want people who are 4s, and so that is something that could be a pro. And then personal reassurance, maybe that's more for if you are worried because you have a family history and you really want to know, like, am I 4? So you find out, say you're not, and that could decrease anxiety and worry for you. So obviously very personalized, all of these things. What are some of the cons? So uncertainty and limited predictive value. I think hopefully I've drilled that in about, despite knowing there's an increased risk, it's absolutely not a certainty that a person's going to go on to develop symptoms of Alzheimer's disease. And there's so many other factors that we don't know yet about that are contributing to one's risk of Alzheimer's disease. So that's a downside. Psychological impact, the worry and the anxiety that the results could cause someone can be, small to large, how that could impact your life, especially for people who are prone to anxiety or may have a lot of stressors going on in their life at the moment. Definitely does not seem like a good fit. And in studies of people who doing ApoE testing and disclosure of cognitively unimpaired people who say had a family member who had Alzheimer's, and so they're more concerned. It seems that the people that had more anxiety after finding out their results were the ones that were the more anxious types before they found out their results. So that's important to keep in mind. Stigma and discrimination risks. This might be the biggest one, practically speaking. So there's no protections still for long-term care insurance and life insurance. So if you find out you're a 4, that may prevent you from getting the life insurance or long-term care insurance that you want. So probably best to sign up for that first and then get your ApoE status. Now, if you find out your ApoE status through a research study, those tend to do a much better job at keeping all of this private, but there's, of course, never 100%. They can say that this isn't going to get revealed somehow, but it's close to that. Then finding out your ApoE status could have impacts on your employment and or social stigma. In terms of family dynamics, there could be situations where a person found out they're, someone who has kids and grandkids finds out they're 4, and that could somehow lead to some kind of strained situation and guilt. Hopefully that could be overcome. And then no guaranteed prevention yet. So a lot of basically everything in medicine and Western medicine is like, we take actions when we think it will change management. So it's going to change something that you do. And if you're, healthy otherwise, and you're cognitively doing fine, there may be nothing, and maybe you're super healthy, you're doing everything right already. There might be nothing else to do with that information. Now, I found this website, genetestornot.org. And so it was developed specifically about getting tested for ApoE. This researcher wrote a book about this, and I haven't read the book, but I found these questions really clear and nice as a framework to go through before you pursue ApoE testing. So, number one, does my family history put me at a higher risk for Alzheimer's disease than other people? That's often these days, what I've seen, the reason people step forward and want this information. They've seen someone go through it. They've been a care partner. Their parent went through it. Their grandparent went through it. They are more in tune with the realities of these diseases and want to take control and try to prevent it for themselves, but also equip themselves and their family with information and awareness about their status. Will the genetic testing give me useful information? Is it based on your personal goals and values in life? Is this something that's actually going to change your life? Are you going to do anything differently? Or is it going to, again, cause increased anxiety and be a disservice for your life and your family members' lives? Is this the right time in my life to take the test? If you are going through major transitions, stressors, medical illnesses, family members have medical illnesses, issues, this isn't a good time. I would say hold off until things are more stable. And that's the recommendation right now, because there's not a definitive clear action if you're cognitively unimpaired, what you will do with this information. Now, yeah, again, when things calm down or with advances in our treatment, understanding of treatments and available treatments, then that may change. And then, will the advantages outweigh the disadvantages? This is very personalized and is sort of a composite of everything we talked about earlier. Now, this website goes through these questions with a multiple choice response, and then it lays out some different data to round out these different areas. And at the end, it gives a composite of your responses and a suggestion for if you seem ready and in a good place to pursue testing. And this is my last slide. I always find it helpful in this field to project into the future of what probably this is going to look like, how thinking about the influence of your genetic status in your future risk of Alzheimer's disease symptoms. And so, in other areas of medicine, like cardiovascular disease and risk of heart attack, your healthcare provider is using, you may not know it, but there's these different risk scores that they're entering in information about you, like your age, your gender, your what's your blood pressure, what's your cholesterol, LDL, and some, are you a smoker, what's your BMI? And then they get a score of, what's your percentage risk of, one of them will say having a heart attack in the next 5 years. And so based on that, they can decide which treatments to recommend or not, depending on how high your risk is. So that's where Alzheimer's is moving. And I put this picture here. This was published last year. This was a big commission, a global commission, to determine what are the risk factors for Alzheimer's disease based on reviewing lots of data and systematic reviews and analyses and studies. And so what they found was that there's 14 modifiable risk factors that account for 45% of Alzheimer's disease. So Alzheimer's disease is potentially preventable by 45%. So 4 out of 10 people, if these were addressed, at the right time in their lives would not go on to develop Alzheimer's disease. And so you can see here, they divide it into early life, midlife, and late life. And midlife is really where the money is, right? That's where most of these risk factors are happening and are wreaking the most havoc or increasing one's risk of Alzheimer's disease. So I'll just go through those real quick. So hearing loss, high LDL cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, excessive alcohol. Now, what I predict is that your primary care will have a risk score that they'll enter in things like your status depending on your age. So say you're 18 to 35. So there's going to be like a number of risk factors and your ApoE status. And specifically, if you're an ApoE 4/4, that's going to kick your risk up to some, increased degree. But it's going to be in conjunction with looking at all of these other factors. And really, these cardiovascular risk factors are huge in terms of, if addressed earlier in life, could decrease the risk of dementia. But then I put other things, so there's environmental, there's lifestyle factors, there's other things so the last talk, we had our interview with Dr. Diego Mastroeni to talk about this link between a common virus that was found in the gut and risk of developing Alzheimer's disease. And it appears that certain people who have a certain genetic findings have a risk of going on to develop Alzheimer's disease. So these are other things that might be looked at in this risk score. And they're also will likely to identify other genes, over time that play a role. I don't know if it'll be as big as ApoE4, but certainly there'll be other genes. Just like, again, in cancer, it's all like genetic molecular risk assessment that's being done. And I think that is it. Thank you for joining, and hope to catch you next time. Take care, everyone.